Well, I'm definitely a proponent of Demi Moore.
Right.
But I'm not here to convince anybody to switch from scleral buckling to vitrectomy, and I want to emphasize that. What I tried to do 2 days ago was to go through the rationale in my brain about the pathogenesis of rhegmatogenous retinal detachment, because that's the process that led me to do what I'm doing now, which is I do not do scleral buckling anymore. But again, I am not trying to convince anybody to do the same. I'm just telling you what and why I do that. So I will just simply continue with a few additional points after my introduction 2 days ago, and discuss a little bit the technique. So the next dogma, if you recall, that's how I went through it on Sunday, is that if you need to attack or deal with a retinal detachment where the break is inferior, then you really have to add a buckle in the phakic eye. And the rationale given is because it is impossible to reach the periphery inferiorly in the phakic eye. And the reason for that, because it is true in certain setups, is what you see on this image. And as I watched some of the videos over the last 2 days, I saw quite a few of the cases which were done exactly like this. So in a phakic eye, if your sclerotomies, the working sclerotomies, are too superior, indeed you cannot reach the inferior periphery because the lens is in the way. And I remember the best book for a very long time written on vitreoretinal surgery was Ron Michaels, his original one. And this was one of the teachings he had in that book, that do not place your sclerotomies there. The sclerotomies have to be just above the horizontal line. And for some reason, this teaching is not so much emphasized today. Because if you do this, it doesn't matter whether the break is at 12 o'clock or at 6 o'clock. So in order to have a complete vitrectomy, and as I said 2 days ago, the key to success is complete vitrectomy. You have to put your scleral buckle properly. Because when we say complete vitrectomy, it means complete vitrectomy. So we often discuss vitrectomy in the periphery, and it's crucial still to leave no or just a tiny amount of vitreous in the periphery, but it is not sufficient. So I just want to show you one method with a newly developed forceps that will allow you to deal with the posterior hyaloid even if it's difficult to detach. But I want to show you this video because, and remember, one of the things I said 2 days ago is that we don't pay enough attention to the vitreous posteriorly. Many times what you see as a PVD is a vitreous schisis. So this is just one case where the reason for the redetachment was that the original surgery addressed the vitreous in most areas of the vitreous cavity, but not the vitreous that is still on the posterior retina. So the reason for the redetachment and the reason for doing a second operation is to address the residual traction that is exerted by a vitreous that is still on the posterior retina. So I want to emphasize again, if you choose primary vitrectomy for a retinal detachment, vitrectomy is not just a core and base vitrectomy, it has to be a complete vitrectomy, starting with vitreous that is not detached over the posterior retina. And I will come back to a second possibility why reoperation is needed, and you can see how much of the vitreous is still there. This is not visible preoperatively because it's a very thin layer of cortical vitreous, and this should be done in every case if, again, your choice is primary vitrectomy for retinal detachment. So let me move on, because there is one additional factor in my practice, which is to remove the anterior hyaloid face. Even in a phakic eye, as you can see, and even if the lens is completely clear, you can do this. The trick that I am using is a small air bubble that will be trapped by that anterior hyaloid, so you know exactly how far you are from the lens. And the reason for this is because this membrane can also contract in the postoperative period and lead to a secondary tear. So, leaving vitreous behind in an eye that has now mostly fluid allows that remaining vitreous to exert traction even more so than primarily, because you have more room in the vitreous cavity to do so. Another trick to complete the vitrectomy in the periphery is what some people call dry vitrectomy. I called it pneumoretinectomy, but we'll have a wonderful talk about this later, so I'm not going to talk about it. So let me just briefly tell you about a few cases I had about inferior detachment with an inferior break. And this is about the need for putting an air bubble or gas bubble in the eye. The role for that gas bubble is not truly what we all assumed for a very long time to be, which is to tamponate the break. It really acts as a mechanism to reduce the shearing effect of the fluid which is inside the vitreous cavity. So if your laser takes effect in a week or so, the gas bubble helps preventing the fluid from shearing off and getting under the retina before that laser takes effect. And one final addition to what I said is because every time I do a reoperation after a previous vitrectomy, I will find residual vitreous. So one thing that you can do to enhance the effect of what you are doing is laser cerclage. Now, if you look at the literature, you will find quite a few articles which will say it is not effective because you will have a new break developing at the central edge of the laser cerclage. But laser cerclage and laser cerclage are not the same things. Just like if you have a car on the left, you are entitled to say cars don't drive at a speed exceeding 150. But if you have a Monaco car, like on the right, then you will not say that. So it depends on what kind of laser cerclage you are performing. Mine is not 2-3 rows in the periphery. Mine, as you can see, it's roughly 1,000 spots, and it's very fast if you do it intraoperatively, and this will prevent, even if there is a new break for some reason in that area, it will prevent retinal detachment coming from there. So basically, as a result of this technique, the primary failure, which in my definition is a failure coming from anything else other than PVR, is pretty much down to zero. And you can argue about how you do this laser, but I don't want to waste more time on this. because I'm sure we have other things to discuss.
But is this to avoid missed breaks?
Yes.
So just to make sure you're not missing a break there?
It is for missed breaks or potentially new breaks developing as a result of vitreous that you really could not remove. Although with experience, it is a much less common effect. And let me just add one last sentence, and I'm not going to play my funny video at the end because of the interest of time. But I want to say that when I looked at my own clinical practice over the last, I don't know, 15, 20 years, all of my surgeries became much shorter during this interval. This is the one exception. Retinal detachment, it takes now more time for me to complete than it used to because I pay attention to everything that I just listed a lot more than I used to.
And what's your argument why you're not going to get breaks posterior to your laser? Because
yes, because the posterior edge of my laser cerclage is posterior to the equator.
To the equator?
Yes.
Right. Okay. Thank you so much. Okay, well, you'll tell us about vitrectomy under air, right?
Okay. Let me start first by re-emphasizing on
I'm sorry.
Yeah. What Ferenc Kuhn mentioned and published before. No.
Mm-hmm.
Okay. This is not the starting slide.
Is that your first one?
No.
So it seems there is a missing slide. Is that your first one?
Yeah.
Okay. Yeah.
Well, what Ferenc Kuhn mentioned has been published before recently in 2014 in a very nice paper because it elaborated in details the mechanism of traction and highlighted also that, and of course stresses on the idea that we need to eliminate the traction to have a direct, straightforward solution for the pathophysiology that happened. But as mentioned also, it is easy to say, difficult to do. And the complete vitrectomy is rather a challenging procedure. It entails a complete removal of the posterior hyaloid, and there is still the challenge at the vitreous base area because there is a contradiction between a meticulous trimming of the vitreous base and leaving a safe retina without iatrogenic breaks at the end. And even though there is a continuous debate about the pump mechanisms, and also there has been modifications in the blade design. These are still in vitro, under in vitro testing, but we are always looking for something that is easy to do and in the same time to have the same effect that we desire. Vitrectomy under air has been proposed by many surgeons before, but for my part, I am presenting to you somehow in details how to do a peripheral vitrectomy under air that ends up with a complete shaving with a safe retina. I usually, after reattaching the retina with the perfluorocarbon liquid, I fill with perfluorocarbon liquid till the posterior edge of the break, or the retinectomy, as possible as I can. And I do some laser, especially in giant hairs and in retinectomies, before I start with the air filling, because you know that there is a risk of slippage of the edge. And I feel that, and I believe that the laser marks start the chorioretinal adhesion somehow within minutes after the laser. And then I infuse the air to fill the upper 1/5 maybe of the globe. So I have two interface, and then I move with my probe at the periphery. The port is usually directed towards my side. I work zone by zone. In each and every zone, I don't make, of course, vigorous movement. I try to be almost stationary or with a little movement at a space. I would like to tell you that even if I stop at one spot and use my the cutting and vacuum settings, vitreous will come to me. I don't need to go that much everywhere looking for the vitreous. And one other point is that I work with high vac. I don't need to lower the vacuum settings to be able to work at the periphery. Of course, since it's possible for me now to cross the ora serrata line, even especially at the areas of the trocars and the cannula, the trocars, to make sure that the vitreous has lost all connections. It is not just it is completely removed, but it lost connections at the trocar site. The point here is that how to make sure that you remove the vitreous completely. You see clearly the vitreous, how the vitreous as a gel is clearly seen under air. I keep working and cutting until there is no gel there at this area. I can control my indentation because I use the chandelier illumination in all the surgeries. So I can control the level of the indentation and the extent of the indentation so that I can see clearly in all the quadrants. Of course, there is a special stress on the inferior 180 degrees of the vitreous base because it is well known to be the site, the scaffold for pre-proliferations and the RPE to elicit a PVR, the monster that we are all worried about in these cases. And I want you to take care that the movement itself, I try to limit my movement as possible as I can so that I can make sure that the vitreous is finished up in each and every space. The main point also to highlight here, how close is the probe to the retina while working. And this is the advantage that helps me to have a complete vitreous base shaving. Air acts as a cushion. Of course, we know that when we trim vitreous in an attached retina, it is much easier. The retina is attached by the air cushion, and the air cushion, in the same time, prevents it from slipping back into my probe while working. The only possibility, in my experience, is to have an iatrogenic break, is to direct your port towards the retina and to dig it into the retina. Otherwise, it is almost impossible to have a single retinal break during the vitreous base shaving. But of course, there are some limitations that you may face because working in an air-filled globe is not that easy and it may need some adaptation to get used to it. And in some settings where the posterior capsule, for example, is deficient and air migrates into the anterior chamber, of course, the glare may prevent you from working. It is very simple. We all know that injecting some viscoelastic in the anterior chamber and sometimes directly behind the IOL may help you at least to finish up the task satisfactorily. There is another point that is related to the chandelier because even though the advantages are great, but there is still a problem at the point of the area of the chandelier itself, the glare that the chandelier caused. Especially that, for me personally, I like to put it, to insert it inferiorly, and the inferior part is the seriously required part to be operated upon. Sometimes I just do some tilt. some tilt in the chandelier that enables me to work on the area that is adjacent without being disturbed. But in other situations, there is no problem to, whenever you feel that you are crippled in your performance, to shift the chandelier from the traditional inferior position to one of the superior ports. And in this way, you see now that the view is, I think, much better. And I'm moving with the probe along the oros serrata and even the pars plana without having any barriers to my work. So this is what I want to say. Of course, I'm not convincing anybody with anything, but in case we do a vitrectomy, in order to have a complete posterior hyaloid peeling, and for this part, the vitreous-based shaving, it is now possible to have a vitreous-based shaving without the need for sophisticated industrial manipulations. I remind you by the end again that I work with high vac settings. The vacuum is in the range 450 to 600, very close to the retina, in a very simple, I think, fashion without any risk on the retina. Thank you very much.
Thank you so much, Wael. For the sake of time, we'll move to Abdullah. So Abdullah, you will show us a technique that helps inducing PVD in difficult cases if you happen to operate and the retinal detachment does not have a PVD as well.
Oh, thank you very much. My presentation is very simple and very direct. I'll talk about a modified technique to induce PVD in firmly adherent hyaloid. As we know that PVD induction is an essential step in vitreoretinal surgery for different disease. Most cases with retinal detachment already have PVD. However, some of them may don't have PVD, and they may have firmly adherent hyaloid, particularly young patients. And this is very challenging, especially in small gauge cutters. As you know that in modern cutters, the companies has moved the tips slightly toward the end of the cutter. However, even with the smaller gauge or with moving the tip, the grasping power of the cutter is much weaker than ordinary 20 gauge or 23 gauge cutters. And this is the main point. The grasping power, the smaller the gauge, the less the grasping power. There are some previous techniques to induce PVD in firmly adherent hyaloid. Some people have tried active aspiration with a silicone-tipped cannula in the peripheral region. Others have tried sharp dissection by a pick or an MVR blade. And some others have tried a non-aspiration technique using the posterior vitreous pocket as a guide to induce the dissection of the posterior hyaloid. Hereby, we propose this slightly modified technique. Initially, we try to induce the PVD by the normal maneuver, by direct aspiration over the peripapillary region. But when it fails after 3 or 4 or 5 attempts or more, we try this technique. We use a sharp dissection by this cannula, which has a 45-degree angle at the tip, and we connect it to active aspiration in the machine. We initially tried this technique with 25 gauge vitrectomy. So hereby we have the controlled aspiration, usually ranging from 300 to 500, and you can control it from the foot pedal, and we try to engage the hyaloid. And once you engage the hyaloid by gentle tangential traction or movement, you can start to dissect it very gently. And once it's dissected, the spread or the wave spread all the peripapillary region, and the hyaloid will become fully dissected, and you move it towards the center of the vitreous cavity. And hereby, this is an example where you start dissecting the hyaloid. First, we tried the normal maneuver, but it failed. And then with the sharp pick, you gradually try to capture it, and once it's grasped, you try to move to the center, and hereby you'll see the PVD wave will start to spread gradually. And this is another case in a young diabetic. He had vitreous hemorrhage and still attached BVD. There were no traction over the disc. So we tried to induce the BVD with a normal maneuver, but it failed. Then we used this controlled technique with a sharp beak with aspiration. So again, I'll stress in this point, in a small gauge cutter, the smaller the gauge, the weaker the grasping power, and this is the main point we use this maneuver. Definitely you will need it in a few proportion of cases of your vitrectomy cases, usually about 2 or 3 in 100, but it really helps. And as you all know, the posterior hyaloid has a lamellar structure, and that's why sometimes, as Dr. Kuhn highlighted, sometimes even after you induce a BVD, there is like a vitreous chiasm or a residual layer over the peripapillary region. And sometimes you can anticipate that with using OCT. If you do like a peripapillary scan and you slightly change the contrast, or you have a machine with enhanced vitreous visualization mode, you can appreciate the attachment of the posterior hyaloid nearby from the disc. And if you look at this example, you can see here how dense are the attachment of the posterior hyaloid, and this how dense is such lamellar structure around the disc in this region. So, and the main advantage of this method, it's very well controlled. So you can control it very well by the suction and engaging the hyaloid. So you feel a good control over the hyaloid while doing that. And if you anticipate a case with firmly adherent hyaloid, you can easily do peripapillary scan or a circular scan around the disc like the one used for glaucoma. And just with changing the contrast, you can appreciate how dense are the attachment, particularly in young people. And you can use this method for OCT-guided BVD induction in cases where you anticipate adherent hyaloid. So in conclusion, this simple technique is a viable option for cases with firmly adherent hyaloid. It's very quick and safe and well controlled, and atraumatic as well. Initially, we tried it in 25 gauge, but you can also try it in 23 or 27. We have recently published this technique in Acta Ophthalmologica, so you can come across it, and we are happy to get your feedback if you have any comments. Thank you.
Thank you, Abdullah. I think the point here is some cases with retinal detachment, there's no frank PVD, and that's the cases, for example, in France and the UK, they're called retinogenic or no PVD detachment, and these cases are usually buckled. However, if you're doing a vitrectomy for these cases, sometimes inducing hyaloid detachment is difficult. So stain, and maybe use a PIC or a combined PIC with suction, as Abdullah demonstrated. We can take maybe one question as we move on to the last part of our session, which is on complex cases and failed cases. Yes, Malhar, please.
I don't understand you're talking about adult cases here, right? It's not pediatric.
I beg your pardon?
You're talking here for this technique for the adult eyes, not the pediatric.
Yes.
Right? So,
yes.
So I fail to understand the reason of failure of PVD induction here. I think, and I don't see the real difference in the process when you use peak and use vacuum. Actually, the cutter would be a lot safer because it's not sharp edge. I think the simple thing what Steve Charles has taught us long time ago, that highest possible vacuum, and then you just move the cutter from the optic disc margin toward the center of the vitreous cavity, not going inferiorly or in any other direction. And additionally, I prefer always triamcinolone marking the vitreous. So I just fail to understand why that shouldn't work and what is the real benefit actually. Cutter would be safer.
No, sure. Sorry, Abdullah, please.
Yeah, this technique is an option. You will probably need it in 2 or 3 cases per 100 where you find very firmly adherent hyaloid. The aim is to create atraumatic BVD induction just to avoid any trauma or any hemorrhage. definitely the usual technique work in more than 98% of cases. But sometimes you may come across cases where a young, let's say 35 or 40 years old patient with firmly adherent hyaloid, and they have like or people who have atrophic hole without BVD, or sometimes the hyaloid is very adherent, and that's why you tried other possible options.
No, sure, but that's what I'm saying, that I haven't come across a situation in adult eye where I couldn't manage to induce PVD.
Yeah, these cases, Malhar, they were operated by me. So these cases, I all tried the cutting and the active suction, and I just could not get a hyaloid separation. And I think the reason is the lamellar structure, and it's very adherent. So you need to perforate in the subhyaloid. It's something optional if you feel.
No, sure, I just thought to share my thoughts.
Yeah, absolutely. But I mean, you might have not come across it. It's, I don't think it's common, but it's something optional. Sorry.
Ahmed, just one quick comment. I think it's key to induce a PVD is not to do a very deep core vitrectomy. So just a little bit of the core vitrectomy to leave a cushion of the vitreous we
Absolutely.
can put some traction on. A risky active suction PVD is really high when you have a thin retina, diabetics with laser and thin retina, and of course in pediatrics. I do a lot of pediatrics, and actually bending a 23 gauge needle and going actively inducing a tear in the very firmly adherent posterior hyaloid, I think it's very crucial in pediatric age group, and we cannot do with active suction in those. So thank you.
Thank you so much. Yeah. Stephen, I'm sorry, maybe a quick one?
Just real quick.
Okay.
Abdullah, I think that this is probably a very valuable technique in post-trauma eyes in young people where you're trying to induce that PVD. And I've tried, I have difficulty. And the tendency is now is, well, maybe we should have waited 24 hours or more to do the vitrectomy, but run the risk of endophthalmitis. This technique may help in those cases.
Yeah, just a quick, The core message also is to try to do a pre-operative OCT. This will make you appreciate how adherent is the hyaloid or how lamellar is the hyaloid. So you can plan that in advance during the surgery.
Thank you, Abdullah. So we'll move on to Jean-Paul. You use aqueous flare emitter to help you predict PVR. So can you tell us about your work?
Yes, I think it's an interesting tool in predicting PVR, and PVR is the main cause of failure of retinal detachment. Breakdown of blood-retinal barrier leads to a rise of vitreous protein, which have a major role in the development of PVR. By microscopy watching for hyperemia, hypotony, retraction of the ILM, curled off edges of breaks, or vitreous hemorrhage was the only way to detect patient at risk of relapse by PVR. So we wanted to know if laser cell flare would have a higher sensitivity to detect patient at risk of relapse, especially in the absence of biomicroscopic signs of PVR. So we made a retrospective study about 100 consecutive patients operated on retinal, rhegmatogenous retinal detachment during a 1 year period. We had preoperative examination consisting in those parameters: extent of retinal detachment, PVR, vitreous hemorrhage, and we made in all these patients bilateral measure of aqueous humor flare using the COA FM500 laser flare cell meter. So the primary endpoint was to precise preoperative flare in patients that relapsed. The secondary endpoint was to find any correlation between preoperative flare and risk factor of PVR, such age, visual acuity, extent of retinal detachment, preoperative PVR. And the tertiary endpoint was to analyze the sensitivity of flare to predict relapse in eyes without clinical signs of PVR. which may happen in quite a number of cases. So this was our cohort. We had the mean age of around 60 years old. 48 patients had no PVR sign. We have grade A, grade B, and 20 patients with grade C PVR, which is quite a lot, I think, more than what we get in general. It's maybe a special population. The mean preoperative flare was around 26 counts per second, and in the detached eye, and it was around 6 in the fellow eye. 20 patients in this series had a relapse due to PVR, and the mean flare in the patient that relapsed at the time of relapse was 60 count per millisecond. Preoperative flare in case of relapse by PVR was quite higher, 48 counts per second. And we found that 85% of eyes with PVR-related relapse had a flare over 15 at presentation. So we could find that a preoperative flare over 15 at presentation, in those cases we had odd ratio of almost 20 for relapse by PVR, with a sensitivity of 85% and a specificity of 70%. So these are our results. We found a correlation between relapse and PVR. Low preoperative visual acuity was a great risk factor of postoperative PVR. Severity of preoperative PVR was also a great factor. Vitreous hemorrhage also, and flare was the highest risk factor, preoperative risk factor for relapse by PVR. And when we are looking to the correlation between preoperative flare and low visual acuity, we found it. Extent of retinal detachment correlate with preoperative flare, vitreous hemorrhage, and severity of PVR at presentation also had a very high correlation. When let's look at the subgroup of patients without clinical sign of PVR, which are the most interesting, because we wouldn't expect relapse by PVR in those patients. This group is 54 patients. We found a relation between PVR relapse and preoperative flare in this patient. We had patients that relapsed, and this patient had a preoperative flare of 25, even without sign of clinical sign of PVR. So we found this very interesting. And if we compare in the other eye that didn't relapse, the flare was only 12 count per second. We found no correlation between PVR relapse and sex, lens status, macular status, extent of retinal detachment, all correlation that were cited before. So in this series, we have of 54 patients without clinical sign, we have 5 relapse. So, of course, it's only 5%, but it's really interesting. The odd ratio, if preoperative flare was over 15, in the subgroup was even higher. It was 19 for a risk of relapse. So this is the important finding of the study. So in discussion, we can say that preoperative flare was correlated with PVR relapse, with a good sensitivity and specificity. If we had a flare over 70 count per millisecond, the probability of relapse was very high, 76%. Visual acuity, vitreous hemorrhage, grade of PVR were correlated with relapse in accordance with previous study. That was not the case for sex, age. We found preoperative flare correlated to preoperative visual acuity and vitreous hemorrhage. Extent of retinal detachment and PVR were correlated to preoperative flare in accordance to previous study. And a flare over 15 count per millisecond leads to a risk of relapse multiplied by 12 almost. In the subgroup without sign of PVR, probability of relapse rose by almost 8% for each one count per millisecond, leading to a risk, an odd ratio of 19. Laser cell flare emitter had a very high sensibility with good specificity to predict the risk of relapse, especially in patients without biomicroscopic signs of PVR. So the take-home message is that laser cell flare emitter has a high sensibility to predict a risk of relapse by PVR in all patients presenting retinal detachment. In retinal detachment without biomicroscopic sign of PVR, laser cell flare was even more performing to predict high risk of postoperative relapse by PVR.